Yeah. Well, actually, what we're seeing with some of the consolidation, too, is a new level of consolidation, which is not an employed model, but the, quote, clinically integrated network, where hospitals in certain regions, they may have a cadre of employed physicians, but they're taking on a contractual basis with community physicians, joining together. Sometimes I think we're facilitating it as payers for accountable care type relationships to participate in value-based relationships. But they're creating tight referral networks that really didn't exist before. And again, it may serve in the long run to drive up costs because it's going to drive referrals into hospital settings. Well, but we're seeing that in addition to the employed model, we're seeing some degree, maybe it's a lower level of consolidation, but into this clinically integrated network.
What I've seen is
So I want to do this. I want to hold that piece of the conversation because to a certain extent, it really ties into the oncology care model as recently been introduced by CMS through CMMI's innovation grants. And so I want to table as we're starting to shift that conversation a bit because I think it's going to fall naturally there. And I want to switch gears just a little bit because we've been talking about, kind of these sea changes that are happening and patient-centered medicine with patient-reported outcomes, the impact of 340B on a tremendous industry consolidation. But one of the other big ones, and maybe impacting oncology more than other, but it seems to be fairly common, is really the development of robust specialty pharmacy pipeline for oral oncolytics and other oral therapeutics. But it's really about the product of understanding the human genome, understanding the molecular pathways which govern disease, and starting to get precision medicine to target those specific molecules. And it seems that how the oral therapeutic growth is going to impact, because that has an effect on payer, this kind of what seems to maybe some as arbitrary separation of pharmacy benefit from medical benefit, the impact on physicians who historically in oncology made their living off infusing drugs in their office and now may or may not be dispensing pharmacies, and not every state allows it. But it really represents another one of these potential sea changes in the ways treatments are given. And even that interactivity with the office. Can you do all the patient-centered medicine when the patient is just getting a prescription and then coming back once a month, in a field like oncology, or does it need that? So Ted, we'll start off with you on this one, in terms of what you're starting to see in the impact of this increasing percentage of oral therapeutics that are entering into the clinic.
Well, it's really tough, Bruce, because if you look at you look at the price, a lot of people feel sometimes mistakenly, oh, there's an oral form of this chemotherapy, or there's an oral chemotherapy drug, and they sort of equate that with aspirin or antibiotics, and then when they realize that price of that drug is often as expensive, if not more expensive, than the infusible format. So what it's done is when we see that 25 to 35% of the drug pipeline is coming out in terms of orals, it's a whole new situation. When you're giving the drug, when you're infusing the drug in the office, there's one thing you know almost total 100% certainty that the patient got the drug. The only little tiny thing if there was an error made in the drug, and so that's minute. So virtual certainty. The problem is now you give an oral drug, you don't know what happened. We've done a lot of research at COA on this, and basically it's actually tied to cost. So when the patient goes into the pharmacy, to begin with, regardless of the cost, 10% of patients don't get that first script filled. So now you're the physician, and even on the payer side, and you say, well, wait a minute, is the problem that it's the drug? Is the problem that the patient didn't take the drug? You've never had to deal with that before. So even when you forget about and put aside for a minute, not forget about, but sort of the reimbursement issues and all of those things, the structural issues within the practice, you have one issue in terms of just clinically of saying what happened. So now you have entered other parties like specialty pharmacy that see a gold mine in terms of sort of managing that. And what's ironic is that threatens to pull out of the practice and disjoint from the practice literally what has been inside the practice, both in terms of giving the product, giving the drug, the therapy, knowing that the patient had the therapy and making a decision off of there. Now you have a whole set of circumstances, and that's without even, I'll come back to it, but if you like, that's not even talking now about sort of the reimbursement issues, the structural issues within the community practice.